Thank you for that. I apologize. Welcome again, everyone, to our November Virtual Tech Speaker Series, AI Opportunity Identification for Healthcare. This is part 2 of a 4-part series. The council hosts more than 100 events each year across Arizona, and we'd love for you to join us and stay connected with us. Be sure to visit aztechcouncil.org for details for upcoming programs and membership opportunities if you're not already a member. My name is Carla Bernal Morales. I'm the Vice President of the Arizona Technology Council, and I wanted to share some of the events that we have coming up. We have plenty still for the remainder of the year. If you are not aware yet, tomorrow we will have our After 5 mixer here in Tucson, the future of flight at Bombardier. If you have not yet registered, please be sure to visit our website, and I'll be sure to add some of that information on the chat as well. Then we will head over to Phoenix for our December 3rd Cybersecurity Breakfast Forum, and then come back to Tucson for our holiday mixer hosted by JW Marriott. And then we kick off 2026 with our 9th annual Arizona Photonics Days, and that will take place here in Tucson. Now, as we get started, please ensure that you're on mute, unless you're a speaker, of course, because then you'll start off the event like I did on mute. So make sure that if you are an attendee, please go ahead and mute yourself now if you haven't done so. For questions, feel free to use the chat feature. Our presenters will address them during the QA session. You can also use the raise your hand option if you'd like to ask your question directly, and we'll invite you to unmute and then ask your question at that during the QA session of the program. As a reminder, today's event is being recorded, and at this time, I'd like to go ahead and thank our sponsors, the University of Advancing Technology, for being our presenting sponsors for our virtual tech speaker series. And with that, I'd like to hand over the floor to Robert Walker, Director of Community Initiatives at the University of Advancing Technologies. Robert, the floor is yours.
Thank you so much, Carla, and thank you all today. On behalf of UAT, we're proud to sponsor this important conversation and the future conversations in this series related to AI and healthcare. At UAT, we believe the future of healthcare will be shaped by technologists who understand both innovation and responsibility. That's why we support forums like this, places where educators, industry leaders, community partners, and technologists can come together to explore how AI can improve outcomes, expand access, and strengthen the entire healthcare ecosystem. On behalf of UAT, thank you. To learn more about UAT, visit www.uat.edu. Back to you, Carla.
Thanks, Robert. We make a great tag team. We need to do this more often. And I'll be sure to put the websites for both of our organizations on the chat in just a few. I also wanted to add another quick note. For those of you that have your artificial intelligence note takers, please know that they will be removed. You can remove them on your own, but they will be removed. Unfortunately, AI note takers are not allowed during the virtual tech speaker series. Thank you so much for understanding. At this point, I'd like to introduce our moderator. Alicia Moura is a healthcare strategist and digital transformation expert with extensive expertise and experience in growth strategy, marketing positioning, and organizational transformation. As a senior consultant at Salty Limo, she partners with health systems, medical practices, and health tech companies to implement strategies that drive patient engagement, operational efficiency, and revenue growth. With that said, Alicia, the floor is yours. Thank you so much for moderating today's event.
Thanks so much, Carla, and thank you everybody for being here. Welcome and welcome back also to anybody who's joining us for our second session. If you attended last month's, you were able to listen to an awesome group of ladies speaking about AI structure and governance. So I think they've set a pretty high bar for this group, but I think they're up to the task. So as everybody knows, AI is a powerful tool set. It can solve real problems when used thoughtfully. But the challenge isn't just whether we use AI, it's knowing where we should and when. And so that's really what today is all about. We'll be focusing on the non-clinical and operational areas like finance, HR, scheduling, logistics, and patient experience. I'm sure we'll a little bit tiptoe into some clinical as well because we can't help it. These are already areas, though, where AI is showing ROI and where the barriers to entry are lower. We've got a great panel today representing a wide range of perspectives from healthcare systems and academia to startups and analytics leadership. I'm going to briefly introduce them, and then I'm going to invite each of them to take 1 or 2 minutes and share a little bit more about themselves. We've got Dr. Joshua Lee. He is the Chief Information Officer at Tucson Medical Center and has deep experience bringing digital tools into day-to-day healthcare operations. Charles Wickens brings a dual lens as a former, now just recently retired clinic section head at Mayo Clinic. He's also a current professor at Arizona State University, where he focuses on innovation and transformation. Austin Wood is the CEO of Fractal Labs. That's a technology company working at the intersection of healthcare, data, and intelligent automation. And lastly, but not least, we have Minky Kernak, who is the CEO of Mercurio Analytics. That they help healthcare organizations make better operational decisions using advanced data insights. Each of these panelists has worked on identifying and evaluating real-world use cases, and not just headline-grabbing ones, but practical, scalable wins that can drive operational change. Let's start by getting to know each of you guys a little bit better. I'd love to know a little bit more than I said about your background and your organization. And I think we're going to lead maybe with one of the best questions that came out of last session, which is I'd love to hear one example of an AI use case in operations that delivered real results for your organization. Why don't we go ahead and go in the same order that I started with? Dr. Lee, can you start us off?
Absolutely. First of all, I'm really honored, flattered to be here. Been about at Tucson Medical Center for about 3 years, but have spent about 25 years.
Dr. Lee, I
overall.
think you're on mute. We can't hear you.
I can hear him.
I'm not on mute. I don't think
I
I'm
can
on
hear
mute.
you.
Oops.
I can hear you perfectly.
Can my other
well.
panelists hear me?
I can hear you as
Yeah.
well.
Austin, can you hear me? Okay.
Really?
Yeah.
Yeah.
Now I can hear you.
Okay,
Okay, that
sorry.
was bizarre. Thank you. I'm
I'm
glad
usually
that was
usually
cleared up.
considered pretty loud, so I'm often nobody thinks I'm whispering. But spent about 25 years of my life in this healthcare IT space, which is, and I didn't come from a technology background, and I don't, with no disrespect to my technology colleagues, it's often about operational change management than specifically knowing the widget. And I think that's we use that philosophy in our journey through electronic health records. We use that in our journey through automating many of the other people processes across TMC. And I think we're bringing that to bear now as we ponder a future with AI in it. And I think that is the real inflection point that we have concluded here at TMC. It's not really a question of, are we going to use AI? It's how is it going to be a partner in key operational changes? I think there's been an incredible pell-mell zeal to try to articulate wonderful ROI calculations, and not to be a buzzkill, but I think many of them will end up being flawed on some extent because you can't quantify every aspect. The change is going to be much more gradual, and you'll just be in a very different place 3 years from now than you were today. But sticking out of the clinical realm, which is a little tough for me, I spent a lot of time thinking about something which was highly practical. So whenever you work in a large, complex organization, sort of policy and procedure management, knowing what to do in any situation is often difficult, and no more so than in human resources. Like for most colleagues, and we have nearly 6,000 of them and 200 employed physicians, knowing what the right thing to do is in any moment takes a lot of human power to answer those questions. So we embarked on creating Humi, H-U-M-I, which is basically a bot that overlays all of our human resources, standard work, policies, and procedures so that colleagues, and we embedded it right in Teams. So we're trying to create these marketplaces so people find all the AI tools in roughly the same place. So we put it there so people would see this cute little human resources robot, and that would introduce them to Spark questions. And so it really took off like wildfire. It allowed us to close our lobby for the HR department because so many questions were actually being answered at point of care. And because we believe in really extensible technology, it was both on Teams Mobile and Teams Desktop. So it was embedded at all the places people needed it. So I think that was a win for us because it met a need that was just so logical. And our next plan is to extend that to all hospital policies and procedures, and then onto the education realms. So that's our story. Oh, now Alicia is muted.
Now I'm on mute. Thanks so much, Dr. Lee. Charles?
Hi, thank you, Alicia, and thank you for my fellow colleagues and panelists as well. It's a pleasure to be here this afternoon. And yes, it's a great question, very contemporary question, right? How do you operationalize this investment in artificial intelligence? And well, at Mayo Clinic, there's no doubt about it that the clinical benefits, there's a lot of operational tie into that, whether it be cardiovascular health or cancer detection, treatment, research and development, neurology. These are the areas that we're focused on, have been focused on for the last several years. Radiology and imaging is another area where there's a major operational component, and it's coming in terms of more of operational efficiency more than anything. No doubt about it. So as we kind of pair off the clinical discussion to the operational discussion, this is just a good reminder to all of us that there's a lot of operational elements within the clinical areas that are benefiting from artificial intelligence today, right? And so it's not future, it's today. But I would like to focus on an area that truly has kind of changed the paradigm for us here at Mayo Clinic and recently retired, right? So I can only foresee just really incredible improvements, even in just the near future over the 24 months, over the next 24 months, and that is supply chain management. No doubt about it. When we look at health systems, we look at medical centers, we are 100% dependent on supplies. No supplies, really no really care ability, no ability to be able to deliver that that level of care that the medical system is intending to do so. When we look at supply chain, we look at what is it about artificial intelligence that can help us with demand forecasting, that can help us with inventory management, as well as areas such as automation and robotics, procurement and cost management. The other piece is resilience. And coming out of the pandemic, and really still emerging from that in many ways, the resilience piece is very, very beneficial by using tools. Now that does not happen in kind of a silo. There has to be a lot of collaboration and a lot of partnership with people that are heavily into helping develop these tools. What we do is we develop a partnership with Oracle Cloud. We have the Texas platforms, as well as Vertex Artificial Intelligence that we partner with. NVIDIA Infrastructure was a big partner of ours as well. And so this happens with that type of level of partnership. The key that we developed early on too within supply chain was what are going to be those key metrics, right, that we measure ourselves. And going back to what Josh was alluding to, is that what is that return on investment, and how can we gauge whether or not we're leveraging these investments in the software development and all the artificial intelligence collaborations that we have. So we look at some of the basics, right? We look at stock out rates, inventory turnover rates, expiration management, all that, and leveraging artificial intelligence to do so. We look at the cost reduction savings. We look at medical systems in general. One of the top costs are going to be the supplies. So we look at cost reduction savings. Is the artificial intelligence allowing us to do better in that cost structure? Price accuracy is another big issue. When you have literally tens of thousands of supplies being used on a weekly basis, how do you monitor and how can you actually predict price accuracy as well? And artificial intelligence has been allowing us to do that very well, and has been a good metric, showing in the positive direction, if you will. And then really looking at order fulfillment speed, right? When we have a surgical operation that's dependent on specific supplies, if we don't have complete accuracy in order fulfillment, then that human error can be eliminated with artificial intelligence, and we've been leveraging that as well. So all of this, right, comes back to some of these clinical areas that I mentioned to up front. But I think that one overlaying metric that we use pretty consistently is, what is the clinical and patient impact of supply chain, right? Using artificial intelligence, right? So kind of getting it back into that. So what are the patient wait times? Are there any medical error rates associated with supplies? Do we have any kind of supply readiness issues for procedures? And those are, I would say, the top three metric that we use to allow us to figure out whether or not we are leveraging our investments in artificial intelligence in a way that we want to. So, well, that's my brief overview. I could talk more, but want to give my other colleagues an opportunity to introduce themselves as well. Thank you.
Excellent. Thanks so
Yeah.
much, Charles. Austin?
Yeah, thanks, Alicia. So I'm Austin Wood, CEO of Fractal Labs, and me and my team have been building mobile apps and web apps for about 10 years. And a lot of our clients are in the healthcare space, med tech startups. We've built a lot of SaaS products for med tech. And in the last 3 or 4 years, a lot of those projects have, of course, been incorporating AI components. And what we really help our clients do is go from 0 to 1 and then also scale beyond there. But we take a very pragmatic approach. So from the very beginning, we're not just thinking about what shiny demos can we build, but what real world problems can we actually solve. And I have lots of examples of different AI solutions that we've built for our clients, but perhaps the most interesting one for me is, what we've been building internally. And so all of these tools that we're using to help our clients improve their operations, we're also using to improve our own operations. And the way that we've been doing that is by building out our own AI across all of our communication channels. So joining our video calls, Slack, email, the code that we write as well. And rather than thinking about leveraging AI for very big end-to-end processes, what we've done is take a fractal approach. Fractal Labs, the name of our company. So we look down at the very smallest pieces and say, well, at the leaves, at the end nodes of all of this work that gets done, what are the lowest hanging fruit that we can automate? Even if it's something that only takes 5 minutes or 30 seconds, and we start plugging in AI and software to automate all of those pieces, slowly start stitching them together. And so we never remove any human from the equation, but just slowly we remove 10%, 20% of the work that they're doing and free them up to think about higher capacity things.
Excellent. I imagine that's got to be an incredibly helpful way to manage cultural transformation as well. It's just not quite taking as big of a bite as changing up a whole process.
Exactly. Yeah.
Minky.
Hi, everyone. I'm Minky Karnice. I'm the CEO of Mercurio Analytics. And what we do is we help organizations, specifically government organizations, modernize and transform their data, analytics, and culture to streamline their operations and navigate complex challenges, as well as the integration and adoption of emerging technologies. And I think one of the main reasons I started Mercurio was because of the impact that we had in social services, which is healthcare, really having that impact. And the one thing that really made a huge difference for me was leveraging AI to address the challenges foster care children go through, the mental health challenges, and the way that we can actually help people, the vulnerable populations, come up in the world. So for foster care, we actually looked at the top 3 trauma challenges that foster care children faced and addressed those, and then matched them to a family leveraging AI. And we improved the placement of foster care kids from 13% to well over 32%. So within that first year. And that to me was so impactful that I told all the other corporate companies, okay, I'm out, I'm going to go do this now. So that's how I really got focused on it. And so for me, it's really about helping people, leveraging technology to help people help themselves.
A different kind of ROI, an even better one. I love it. Thank you, guys. So I think let's move into our first topic. And I think this will be slightly different for Austin, but still applicable. What makes for you guys a use case worth pursuing in an operational setting? How do you distinguish between a good idea and a good opportunity? Austin, of course, how do you help a client steer them, potentially if they come with a great idea that maybe isn't so great, how do you help them to assess that and bring it into the implementation phase? And also, I think a part of that nuance is helping clients and helping your organizations understand which tool in that tool set is the proper one to use. I know Minky and I have had conversations about, really it's not just throwing AI here. This could be a simple automation or et cetera. So really kind of getting down to what is the right tool set and how do you determine or help a client determine what's worth pursuing.
Are people complaining about it? Right? Are people within the organization actually complaining like, oh, this is really hard. This takes a long time. It takes a long time to train new people to do this. If there's already like actually complaints, if the problem can be felt, then that's generally a good place to start. If it's just a cool idea, like, oh, this could probably be automated with AI, but nobody is complaining about it the way that it's currently done, then that's usually something that is just a shiny object syndrome, right?
Yep.
I think that's so spot on because I think we start with, a lot of people are starting with the tool and finding a problem for it, right? And it's actually looking at your organization and finding what is the technology that's going to fix it.
I wanted to highlight two things. One was, I'm so glad we're beginning to call out the differences between automation and AI, because there's a lot of work to create hyper automated processes, and I don't think that work should stop. But AI is really different because it's expecting and learning from a bunch of inputs and constantly getting better. Like if it doesn't meet that criteria, it doesn't qualify. I think we're very sensitive in healthcare because we often think about there are certain roles that only a human can do. I think we're going to fool ourselves. There's a lot of roles where you don't actually need a human, but we'll cross that bridge when we come to it. But specifically when we look to non-healthcare industries and we see people who can get through an entire work process and never have to actually deal with a human, but then have a human at that endpoint. I'm a little bit of an av geek. I love aviation. People contemplate a very complex international journey on 3 airlines, and they literally don't talk to a single human. But at the moment that you're making sure that you're okay to board that plane, that's a human. And so literally through its credit card authorizations or creating an itinerary or picking your seat or getting meals 24 hour advance, all of that is a non-human moment. So I think we ask ourselves, is this the kind of workflow that is amenable to non-human? That is a big decision point for us.
Yeah, that's a really great point.
Right on. I think I would just like to add to it. It really depends on the institution's focus, right? Where do you want to start? Where do you want to put your, kind of energy and effort? Without question, with Mayo, it's research and development, right? So when you look at some of the major benefits that can be gained from leveraging big data sets. And having the ability to be able to, kind of de-identify the data and have the ability to be able to use robust training models with that, you're saving tons of man hours, right? And literally it translates into years of man hours. So that's been a big focus, right? And looking at it, it's kind of like an AI factory, right? If we can leverage AI in a way where our research and development's been significantly accelerated, then that's going to translate into finding better solutions for either a genetic solution or some other type of rare disease state, or some other type of predictive model that's been kind of out there but has not been resolved yet. So that might not be the same kind of focus, right, for perhaps another medical center, right? But for us, it's research and development and having that ability to be able to leverage precision medicine, AI, using it as kind of like a partnership model where we can leverage NVIDIA, Google, Microsoft, Cerebras, all the advanced infrastructures that are out there, leverage that and be able to really accelerate the research and development.
I thought, Dr. Lee's point on finding where in that process the human is especially important is an interesting thought. Instead of the attempt to look at a value stream and see where AI is valuable, it would evolve to a place where we'll start looking at where is a human valuable and being demanded or requested or a value add, and then plugging that into the process. It seems like it would be a very interesting evolution. On that note, do you, at your organizations, what do you guys have in place for problem clarity, et cetera, when you're trying to move into that technical solution? What do you generally utilize? Is it a formalized process, et cetera?
We have a very large workforce, but also we have a couple embedded tools that are unique to healthcare in the sense of an organized medical staff, in the sense of things called nursing practice councils that we really want to rely on. I think in an ideal organization, you're always relying on those who are closest to the work to identify what they want changed. It's interesting. There is a constant tension in healthcare between sort of top-down change and sort of bottom-up. But I'm actually really curious, like for people who are actually developing the solutions, like Charles and Austin and Minky, who are advising, like how do you get that front seat input to understand what's important? Now we have things that we think are important because we're externally judged on them, patient satisfaction, how many people die under our care. Like there's some things that are like no brainers we have to do, but there's the little pebbles in between that really make for employee or patient or colleague happiness and family happiness that I don't know that people who are sitting in a C-suite can always see. And so I think we need to hear from others. This is a little like revolutionary, but I think we want to change how we know what to work on.
So we actually look at your operations and walk through the entire operation. And when you were saying figuring out where the human is important, we've got a process capability mapping that we, as an enterprise architect type of engagement, we map out your entire organization and find the gaps. And as Austin was saying, find the low-hanging fruit that you can have a huge ROI and see that win. Because when you have a project that takes a year to implement, people get bored. And so having those quick wins to say, oh my God, look what's happening here, and understanding where automation works, where AI works, and where that human has to be in the loop, especially in healthcare. Well, majority of the people that go to any medical facility is for something serious. When you're well, you don't really go to the hospital or your doctor. So, where does that human have to be in place? And really understanding where the gaps are. And that you can only do by doing a process and capability mapping of the organization. That's the first place we start.
Yeah, Mickey, I applaud that as well. We look at healthcare and we're so human resource dependent, right, in terms of repetitive task. Automation, robotics, and AI-driven robotics and automation, by doing that first step that you're alluding to, allows us really to hone in on what's most important, right? Where to start. a couple examples come to mind in that area, you know, especially over the last couple of years, the last 24 months, and that's in the surgical suite. You know, having improved automation, artificial intelligence driven robotic automation with simple things like making sure that the correct supplies are opened during a specific procedure has been a dramatic improvement for the staff as well as for the cost equation. That's a simple yet what once was before a very labor intensive task that had to be mapped out. And once that was mapped out, I was like, okay, let's automate this. Let's use artificial intelligence to help us automate it. So I wanted to share that example and kind of you know, applaud your approach to you know, getting to those root cause opportunities.
And I'll just add also to something that Minky said, but you know, give them those quick wins early, right? But additionally, get feedback on what you're shipping early, right? So so many times the business owner or the department head will have an idea for what could be automated, what could be built, and you get that smallest version out to them, let their team start using it, and that sparks other ideas that you didn't see early on. So if you commit to a 1-year plan, like Mickey was saying, yes, people will get bored. And also you might miss opportunities to have built something even more impactful that you would have noticed if you would have been getting feedback from people earlier on.
So once you've got, you know, you've done that, so it sounds like that's the kind of best practice approach is to do the full capabilities map. Once you have identified that potential use case, how do you evaluate and add in then feasibility, risk, and ROI, taking into account Dr. Lee's point of, and Minky, of ROI not always just being a monetary value, but also an impact value as well?
Is that for me?
Anybody.
I think that so when you do that, right, you do the foundational level, understanding where your gaps are. You're also understanding who your stakeholders are, and it's not necessarily the people that you think they are. And you know, finding the risks, like we had in the last session. A lot of organizations are just doing AI governance when it's far more than that. It's organizational governance, and AI just is one piece in there. So understanding the impact you have, doing impact analysis for that impact line, understanding the risk to those downstream systems, whoever's impacted, be it your patients or the patient's family or the doctors, the facility, or whatever it is, but really understanding the risks there. You have to do that RACI and things like that. But understanding if that risk is even worth it. You know, if it's going to be, and here's a generic one, if it's going to upset your customers, you know, is having a bot answering your phone and automating everything going to be the right solution for you, right? So looking at not just the technical impact, looking at the organizational impact as well as your customer impact. So you have to look at everything. And I think a lot of people just are still focused on what's the security risk, right? Without looking at the other risks that are involved.
Right. And I think healthcare has I mean, there are certainly other industries that do, but healthcare probably is one of the most that really has that kind of double stakeholder group, right? So it's always that question, and everybody understands that, yes, the patient is the end goal, but the facilitation of all of these things is what does help the patient. And so really our stakeholders become our clinicians and our physicians and those that are giving bedside care, knowing, you know, that final goal is the patient, but that is really the stakeholder, I would imagine, in a lot of these processes and projects.
Well, you said it right there, actually. Another stakeholder is compliance, right? Mm-hmm. So how is that one solution going to impact anything that you bring in? And really understanding, so having that solid foundation of the organizational blueprint, understanding the impact of the integration of two solutions. And does that put you out of compliance? Because healthcare is one of the most highly regulated. And that you really have to think about is long-term downstream impact.
Yeah, I think we talk a little bit about the human capital risk, and there's two of them. So I try not to be a fuddy-duddy, even though I'm an old man now. But trained in a really different era in medical education. I have to admit, in the quiet moments deep at night, I worry: are medical students going to remember how to actually examine a patient? Are they going to remember, how to take a history and then process it in their heads? And I actually think that, because I was challenged by my CEO exactly on this question, and she said, well, look, I was a nurse, and 20 years ago, a skill I had to have was to count the number of drips in a microchamber to know how fast the fluid was flowing. And nobody would ever expect that skill today. So the skills that we're going to need are going to evolve. The risk is knowing the right moment where you can give up the old skills because it's safe enough. Because there was some point at which pumps became accurate enough in measuring the infusion rate that you could stop counting the drips manually. And I think our biggest risk is not knowing that shifting point, that we have to be vigilant to know when is it the right time to let go of the skills. Like I do still believe, and again, this is sort of simple country doctor speaking, that I have to be able to integrate a whole bunch of inputs of the history and the exam and lab findings to tell the patient and family a coherent story. Like, I think AI can summarize, but I don't know that it can guide patients yet. But there will come a time that it does guide. I think our biggest risk is missing that moment, either by letting it go forward too fast or holding ourselves back too long. There's a risk either direction. This is a very theoretical space I'm describing, but it's knowing when I'm going to jump across that chasm and I'm still safe on the other side.
Yeah, and just to add, perhaps a bit of a different slant on the non-human side of the risk. Healthcare is a very, very fragmented data set, very, very fragmented, and that in itself can be a showstopper, right? Especially if you want to leverage AI in any kind of expeditious fashion. So there has to be an acknowledgement of the healthcare institution's data set. Is it overly fragmented? Is there an opportunity to help collect, centralize high quality data in a way where it's not as fragmented? Might be a good place to start as well.
And we talk about these systems being safe enough, right? And I was listening to an interview recently with Andrew Karpathy, who was on the Tesla self-driving team, and he said that they called it the March of Nines, where every order of magnitude improvement, to get to a system that works 90% of the time, it might just take a few months. It's not that hard. But then to make it 99% accurate, that takes just as much effort as the first 90% took. 99.9%, you have to put that same amount of effort back in. So 100% will probably never be there, right? So part of it is just what's the appetite for risk, and how do we balance that?
Fair.
And I think that, what Charles is saying is that the fragmented data, I find that most organizations that really succeed with AI have a solid data foundation. And I know I always go back to data because that's what actually fuels AI, and that is what does it. But that data becomes the distinct advantage for every organization. It's that DNA. And going back to what Dr. Lee was saying, what scares me is that when we start stepping away and we're not teaching the skills like that nurse was talking about, how do you know when it's wrong? That's what scares me about AI is we will stop learning certain things and we won't know when it goes off the rails. And that's something to go across every industry.
Yeah, there is that challenge in self-learning because it propagates the idea that it's right because it sees it a lot. this happens sometimes in the development of sort of healthcare research where you're operating on an assumption, like a hypothesis that seems so logical. It happened a long time ago with a drug that used to suppress funny heart rhythms, but in the end, more people ended up dying of heart attacks if you actually gave it to them. And it's because we engage in an echo chamber of belief. And I think to Minky's point, still having a gold standard, because when we think about diagnostic tests, we always want to have a gold standard that says it's true. It's like either positive or negative, and then you compare the test against the gold standard. And I'm wondering, where is the truth gold standard in measuring an AI model? Like, will we always insist that there's a human validation of the gold standard to say good enough to go? And I think this is like probably technologists sit around and think about this late at night, but it is a
Hopefully.
core challenge. Yeah, it's a core kind of ethical challenge in healthcare. And so, Minky, I just want to celebrate you're saying that. Like, when will we know to correct it?
Ooh, those are big questions for sure. All right, so if we're now moving through the process and moving out of idea stage and into pilot. A lot of organizations struggle to bridge that gap, though, from pilot into scaling. How do you move from a list of opportunities to an actionable proof of concept, and then more importantly, move from that proof of concept into a larger scaling implementation? In particular, how do you deal with the cultural challenges of moving from adoption from a small motivated group, as Dr. Lee pointed out, is often the case in pilots, to a less motivated group?
Back to my very first answer, if it was solving a real problem that people have, then motivating people to use it shouldn't be an issue, right? So if you picked a good problem to solve early on, then adoption later on can not saying it'll be easy,
Austin,
but at least less challenging.
Worked in the big hospitals? We would hope.
No, spot on. Is it a real problem, right? I go back to, the initial question that you asked, Alicia, as well, and that is, have you identified your risk, right? Do you have a data set that's going to allow you to have productive artificial intelligence leverage? Yes or no, right? If not, address it. Do you have data security concerns, right? If indeed you do have loose data security issues that need to be resolved, you might want to resolve them first before you start leveraging, generative AI and start, getting into trouble, right? I.e., you only have to have one or two bad events, right? And now that clinician and staff trust and resilience, that Dr. Lee was referring to, then now you've just amplified it by a factor of 10, right? So perhaps before you start, look at, okay, do we have, some significant security issues that need to be resolved? The regulatory ethical issues, I think you have to, and this is just my perspective, I think because everything is in such flux right now, whether it be with the FDA, the Joint Commission, and the other regulatory bodies, then you almost have to say, okay, what type of imposed regulation do we want to have as a medical system, and take that approach, and try to guess where the federal government and the state governments are leading, but try to be as proactive as possible. I think that will help as well with the trust and the resilience on the clinician side, showing that you really are thinking about some type of controls, and having that ability to be able to measure that. So a good place to start is looking at that risk. Yes, indeed. Yeah.
Really curious, and this may be more applicable to Charles and Dr. Lee, but at your organization, who owns that process of turning, not only ideas into pilots or prototypes, but even that, that larger scaling? Where does that live within your organizational structure?
Well, in many healthcare organizations, information technology ends up being the default operations consultants. We don't really want that job, just to be clear, but we are, just because we tend to house most of the project management, and we're part of the technology solution. But inherent, a boss, very wise boss once said to me, you are always a project manager and you are always a consultant to the organization. Like, think about that's your job. And so I do think it resides there. I think in highly evolved organizations who have very, very qualified process improvement teams who are well trained in change management, they take a better part of the burden because they ensure those strict rules around project discipline are in place.
Mhm.
And not kind of the ersatz stuff we do in IT. I mean, we're good project managers, but we weren't always trained as operations consultants. I think they're slightly different. So I do think, I was going to harken back on the last question a little bit. Part of the reason why you get stuck in pilot, and this dovetails well with the operations consultant, is because you didn't change the process before you implemented the technology. So a good thing right now is we're thinking a lot about bots for scheduling, right? Who doesn't want to talk to a bot to get your appointment with your gynecologist? But if we haven't done the hard work to make sure that the schedules are actually open and don't have false blocks in them and don't have weird restrictions, like I'm only going to see 2 new patients, in an afternoon, the bot can't do any better job than a human can. And so what I would say is that we talk a lot about AI governance, and I think we need to think about a new role of AI enablers who really are that bridge between project management and change management that will pave the way to make, because no offense to technologists, I don't think the technology is the problem. It is the getting the organization ready for the change. And so that's my 2 cents on where I think it lives versus where I think it should live.
So in a sense, you're saying the technology is not only not the problem, but it's not really the solution either, or it's only a part of it down the line.
Well, I'm gonna riff on something Austin said. Where people are complaining tells you where people are begging for the fix. But you have to help them get ready for the fix along the way. That's what I'd bring it there together. It's not, it can absolutely make the solution infinitely better.
I totally applaud that because it's what I call the evangelist or enthusiast is getting the organization excited because if something's coming down, majority of the people will say, oh, this is fantastic. In their heads, they're thinking, this is my job, right? So they want to be that team player. But how do you get that organization to actually get excited about it, truly excited to embrace it? And being a technologist and a transformation for my entire career, that is the one key aspect of any successful implementation is getting the people behind it. Because if you find that one person, and this is my little trick that I do, I find the one person does not want it to work. And it's, okay, I'm going to date myself here. It's, if Mikey likes it, it's got to be good, right? So basically you find the Mikey of the organization and they become your best evangelist. And it can never be someone from IT or someone from a consulting company or a technology. It has to be internal and getting everyone enthusiastic about it. And that's the way to really have something be successful.
Yeah, and just to add, having it physician-led can eliminate a lot of the barriers, whether it be an operational type issue that you're trying to resolve. It doesn't matter if even if it's 100% operational, having it a physician-led discussion can really help eliminate some of those resistance barriers that everybody runs into, for sure.
And I still keep going back to Austin's, thought to or practice as well in like taking that piece so that there's not that pressure of change that is so overwhelming. But then, to your point, Austin, if you're getting 5 minutes back in your day or 10 minutes, I think it somewhat mirrors, any of our personal journeys with AI. When you start messing with it a little bit and you get this big time save, or it's pretty good. And so then you dive in a little bit more and can I do this? And oh my goodness, I can. And so you file that away. And so that becoming the same type of mentality in a larger organization process too, makes a lot of sense.
Yeah. Yeah. I think everyone else really touched very well on the operational change, the challenges in going from pilot to scale. Something else that we had talked about earlier when we all met was the costs. I don't know how relevant that might be to some of the people on the call, but that's also where my team really comes in. Is we say you get a pilot working, but it just would be cost prohibitive to roll it out to company wide. Right. So we go in and we say, okay, we've got this AI model doing this thing and this one doing this thing. And what actually has to happen? How can we use cheaper models? Maybe instead of asking one question, we ask, a cheaper model, 10 different questions, and then source all that together to get the same effective result at a much lower rate. So there's lots of interesting things you can do once you get that pilot working, even if it, you couldn't roll it out because of cost reasons. There's ways you can re-architect it so that it could be so.
Yeah.
So I
totally
have a
makes
question
sense.
for you, Austin. Actually, I have a question for you. So when you're doing that, and let's just say you're doing a pilot, right? And all of a sudden you're scaling it across the organization, and the consumption is a lot higher than what you would have really thought it would have been. Because we've done such a great job getting everyone enthusiastic about it.
Yeah.
How would you control the cost at that point? Because now you've implemented it. Do you have to go back and re-architect it?
Sure. So the architecting is a never-ending process, first of all. So ideally, you look at what the usage is in that pilot group and you extrapolate that out. And you can know ahead of time whether or not you're going to be in trouble before you do a big rollout. But if you do roll it out and you need to, work on it, as they say, like fixing the plane while it's in flight, right? That's something else you can do. There's lots of approaches. Like I said, usually it's switching out that really expensive model for a smaller model. Now you tend to lose some intelligence or other functionality when you do that. So you have to get creative, right? Do we maybe instead of asking one very complex question to the model, we figure out how can we ask 5 or 10 much simpler questions that a much cheaper model could handle without any problem. There's also fine tuning the models. So if you have very consistent data sets, then you can take something like GPT-4 and you can pay a one-time fee to run the data that you do have through the model and fine tune it. And now you have your own kind of clone of GPT-4 that's been fine tuned for your specific model set. And now the benefit of that is now you can ask it questions, whereas before it would have had to take in all of your data as input tokens to learn the patterns. Well, you don't have those input token costs anymore. You have this fine-tuned model that just has that knowledge baked into it. So those are just 2 of a dozen different strategies that we use to get the costs down once you want to roll something out beyond pilot.
You mentioned too, Austin, when we spoke before about, even getting involved and starting pilots, even at times knowing or finding out that it is too expensive only because the evolution of the price and technology and things getting cheaper over time. So that's out, it's on the shelf and you're just waiting, to pull that off.
And yeah, because sometimes it takes months or years to get your data pipeline together, everything cleaned up. So as you're putting all those pieces together, you might see, yeah, this is going to be too expensive when we roll it out company wide, but that's today, right? It seems like every 3 to 6 months, they're getting the models. The models are getting, half as expensive and twice as intelligent. So assuming you can extrapolate that out a couple of years, start putting those pieces in place now, even if you're not ready to roll it out.
When you're looking at, looking at bringing in these innovative technologies and solutions, how do you balance that innovation? Not just at the project level, but really across the organization. How do you balance your innovation with oversight? I know this is something that Charles and I have spoken about at Mayo and their journey and how that evolved over time. But I'd love to hear how you all kind of tackle that.
Oversight's a huge word. It's pretty much like an umbrella, and I think that you really have to know your stakeholders. You have to know that impact. You need to know who's affected by it, right? And oversight comes down to the governance of it, and in all aspects. It's not just technology, customs, finance, it's security, it's compliance, it's everything. And oversight can grow out of control if you're not orchestrating your agents correctly, if you're not orchestrating the implementation, right? They can create huge gaps. And we've seen a lot of very disciplined companies have huge security gaps that they didn't even realize existed in their technology companies. So that oversight has to be meticulous, and you have to have someone that is, I'm just going to say, a control freak. They have to be, because there's too much at risk.
Yeah, and the innovation has to be tied into something that's measurable, in a way where you can say, okay, well, yeah, that investment, right? And as Austin, kind of articulates very well, is that it might be a moving target, that investment, right? Especially over several months and years. Okay, you just dumped in several millions of dollars in doing predictive demand forecasting for all of your supply chain. You measure it, and then you kind of like reassess, okay, is it working? And then you might have to say, okay, we need to invest in it more. Or you might say, okay, this is it. We're not going to get any more return on this. We've missed on maybe several of the metrics. Maybe it's time to de-invest. So does the organization have the capacity and the tolerance to say, yep, maybe we didn't really focus on the right problem or focus on the right tool set. Let's de-invest. And that's also a big part of that decision process, and the stakeholders to be able to de-invest when the metrics are not showing you, the results that you're looking for. Failure, what's that old adage? Failure is the first step of learning, right? So there's a lot of failure that has to go on, right?
And I would challenge us not to abandon sort of an aspirational North Star to guide what to work on. Somebody somewhere thought, what if I didn't need taxis? What if I could connect, people to cars? Just 2 weeks ago, we sat in a room and we said, what if we didn't need primary care doctors or doctors at all to decide what's the first diagnostic pathway that gets you on the journey either to better wellness or cancer detection or even chronic disease management? For so long, we've been stuck in this mentality, and I'm guilty. I am a doctor, and by the way, nobody should call me Dr. Lee. It's just Josh. But it is this idea that you're willing to say what would be revolutionary, transformational, and that will guide you to the both AI tools you need and the pathway. Because for so many patients today, healthcare is just a bunch of barriers, getting in to see the doctor, having the doctor make decisions, getting things ordered, getting things scheduled. What if we eliminated things that you don't really need humans for in the process? And I think that's how it guides you. Because I think, Alicia, your question is where and how do you make the decision of what to work on? Ask yourself what would be so different than today we could barely imagine it.
Mm. All right, so a big
Can
one.
we get rid
Oh.
of, can we get rid of that registration process every time we go in, please?
Yeah.
I started refusing it actually. When I'm a repeat patient, I started refusing it and told them, no, it's all in there. There's nothing different. I'm not going to fill out this form again.
Right. Now, one of the questions is actually, what's the root cause of the barriers? So a good example is, and for anybody who happens to work for an insurance company on this call, I apologize in advance. But a lot of the requirements are our sort of slavish acceptance that we have to revalidate insurance details each time. But heuristically, we know who you are. We really do know who you are. And trust me, the insurance company definitely knows who you are. And that doesn't require, like, Minky is making an appointment from exactly the same phone. There's no different details in who she is. We know what her insurance is from last time. We can automatically reach out to get the validation that it's still active. And we only really reach out to you if there's a problem. And I think that if we are willing to challenge that assumption that you need human registration, that you need someone to validate details that are really quite known about you. Like, again, not to, even though I'm obsessed with aviation, think about TSA PreCheck. That's all a bunch of heuristic algorithms that says, Josh flies United. This is his driver's license. I don't get stopped. Like, it's just very, very facilitative. And I think we have to, Minky, I'm so glad you said that, because we have to challenge the barriers that we've always thought we have to do this way, but we really don't. We don't need registration. We need one registration at one point in your life, but we do it every single time.
So we just get rid of the insurance companies, basically.
Well, that's a whole other.
Perfect. Solved.
I might get canceled. I might get canceled.
Oh.
What, from your perspectives, what determines whether an organization is ready to take on AI, and not just technically, but culturally and operationally?
Well, I'll just take a quick stab at this one. When we look at the readiness for the workforce, right, it really does start at the college level, right? And I think what's very, very encouraging now is that we look at the medical programs, across the country. I can speak for ASU. The curriculum is like you've never seen before. It is just rich with big data education about, how to leverage technology, how to even interpret, bad technology, and reject it, right? And have that awareness. And that's a core part of the programs, right? That are emerging and that are in place, in some places today. So I think part of it is generational, and part of it is, okay, if we stop kind of ignoring these incredibly important tools at the medical school level, and accelerate the training at all levels within the healthcare institution, the adoption is going to be, I think, increasingly easier, moving forward. So I'd like to just add that piece of it, and then turn it over to my colleagues as well.
Josh, I think you said last time it's a matter of survival, right? Not are we ready for it, but if we don't adopt it now, will we be able to compete, right?
Mm-hmm.
Yeah, we have to live with it, not fight it, not love it excessively. We have to learn to cohabitate. I was about to quote, I think it's something, Othello, a man who loved not wisely, but too well. And it's like this idea that you have to be cognizant of it. It has to be part of your life, but you also have to balance your affection for it. And that's why I think teaching effective use of a tool, when clinically we always talk about risks, benefits, and alternatives to treatment. And I think the same watchwords should be used, meaning, like, what are the benefits? What are the risks? But what are the alternatives? Is automation better? Is a human better? And sometimes it's not. I mean, AI is often better. But if we go through that 4-part algorithm each time, I think we're going to be really secure in the knowledge that this was the right tool to pick.
And I think that, the people that are just ignoring it and putting it on the side, they're actually harming themselves, because eventually when they do come to realize that, okay, it has become this very powerful tool that we now want to bring in, they're going to have that catch up. So even if you don't adopt it today or implement it today, keeping yourself informed and educated on what it can do allows you the ability to adopt it when the time is right. And I think those are two different schools of thought, right? I'm just not going to pay attention to it, or I'm going to learn about it. And that's a way of just bringing it in slowly. I think that is the key. Like I think Austin said, that you're just going to go away, and you might, right? You might. But I think that we all evolve on different times. And as we evolve and we say, oh, this is fantastic, because I was the last one to have a BlackBerry. Let me tell you, I think I was the last BlackBerry owner in the world. And I loved my BlackBerry, but then I got the iPhone and I'm like, okay, fine. But eventually, as long as you know what's out there and you're not missing out, because the way that you go away is you're missing out and you're not offering the services to your clients or your staff. And now your staff is going away, your clients are going away. That's how you're going to just jump in and get yourself in trouble if you don't know what you're doing.
True.
Yeah, I think that idea of knowing what's out there in terms of, that question of always, what if we could? And maybe that ties back to Josh's aspirational point as well. But I think even if you aren't adopting, but you are continuously starting to understand what's possible, and then reflecting back on what would be possible for your organization, at least that thought process is incredibly valuable. As I've seen individuals and organizations start to make that transition, that seems to be that driving piece when you start kind of creating those hypothetical what ifs, and then they're made aware that actually isn't a what if. If they want to move forward, they can, or when they're ready, they can. I want to just kind of move into one last kind of closing piece, because I want to make sure I leave enough time for questions. But if you all could give one piece of advice to a healthcare leader eager to start identifying AI opportunities, what's the first step they should take tomorrow? Or maybe next week?
That's a great question. I think it starts at the leadership level with that healthcare institution that's juggling all their priorities, right? So if the priority is that we want to kind of like test the waters with generative AI, perhaps what's been said today with all my fellow panelists is a very, very wise perspective, and that is, let's start with a real problem, right? And let's scale it. Let's make sure it's scalable, and let's have the opportunity to trial it in a way where we can get our feet, kind of like a firm foundation of how we do it. How we actually as an organization can do this. Start small.
I would use the count the drips analogy. Think of something which has to get done. You'd never miss it if you didn't have to do it yourself ever again. And it would actually open up your brain for other things. If it meets those three tests, it's probably worthwhile. Like, it has to be a task that is absolutely required. It can't be a discretionary task. So required task, complete happiness to abandon the task, and it actually would liberate mental space to do something different.
I love that counting the drips story, Josh. I'm going to remember that for a long time after this.
Yeah, you better credit my CEO, Mimi Kumler, for that one. She's the one who counted the drips.
I'll make sure the follow-up paper has that there.
Okay.
So I think, piggybacking on what Josh said, that's a great heuristic, right? Like, what would be something that you wouldn't miss, right, if it got rid of it? And there's a great XKCD comic, Should I Automate? right? And it's just a table of the number of times you do something, let's say over the next 5 years, and how long it takes you to do the thing. And then all those blocks are filled in with, the number of minutes or hours or whatever. And it says, if it would take you this long to automate it, then automate it. If it would take you more than that amount of time, then don't waste your time automating it. So I think, yes, look at those things that people would not miss if it were gone, but also take a pragmatic approach. Say, well, how long does that thing take? How often do we repeat it? And what time scale do we want to see our ROI on? Do we want to see an ROI in 6 months, 3 years? And then you can really easily just assess, okay, it's going to take this long to build an automated solution. Should we do that?
All right. So for all of everybody else, if anybody has some questions, either pop them in the chat or raise your hand, and feel free to ask out loud. Let's see if we've got anything in here.
So I have a question for Charles and Josh. What was the biggest unexpected result that happened when you were implementing something or thought?
I would say, and I'm not trying to sell Microsoft here, but I would say that the degree of AI adoption and automation and use of tools that happened amongst our leaders, once we just let a couple tools out there, which was basically like Teams recording of meetings and recap and this thing called Facilitator, like we didn't even try. We just said it was on, like that's how Microsoft works sometimes. Like things just suddenly appear. And I don't know how they do it. And like within 2 months, we get these reports back, from our tenant, and it shows that like 60% of people who had this Teams premium license were already using it when we literally didn't do anything. And I have to admit, some of the magic here is that tools just get out there and people start using it on their own and they organically adopt it. And then you like look back and you go, oh my God, how did I ever live before recap? And it's just, that's kind of weird because in EHR implementation, you train and you measure the usage and you have to fight every step to make them use order sets. Like it's like a trench warfare. And this was like, boom, they just took it on. I have to admit, one of my biggest surprises in the past year.
Josh, I have just a follow-up on that, just with having a little bit of knowledge of TMC that I do. Is that something then when you're looking and seeing where there's kind of a lot of people on a particular use case or just interesting ways that you're seeing that trend happening? Is there a place where that is then living or being communicated out to the organization to kind of then capitalize on that organic adoption?
Right. So we have started to ask the question of what are the things people would get rid of. Like people had made noise about, oh my God, minutes. We hate, nobody wanted to type minutes. Nobody wanted to review minutes. Like it just became a thing. And so that is really, yes, I think that we've asked the leaders themselves to identify the things that they feel are the lowest value.
Yeah, and I would just add, I wouldn't call them so much surprises, but probably the best way to say this is that it took a lot more investment, especially in the areas of, bias and fairness. So, the big concern, right, and it goes back to the data sets, is that they're historically biased, right? So, what kind of system are you going to invest in, whether you co-develop it or develop it yourself, and making sure that you can validate the platform and then have a high level of confidence that you're addressing the biases as much as possible. I think the other one that it's worth mentioning is what we call the black box problem, and that is that, and it goes back to that buy-in issue. And what comes to mind, with some of the major advances in imaging, with artificial intelligence is that, okay, if this artificial intelligence is treating me and giving me information and it appears to be a black box and I don't understand where it's getting this information, then that has to be addressed. So we took a considerable amount of effort in trying to make it less of a black box. Those are the two areas that I probably would mention as not necessarily surprises, but took a considerable amount more investment to address.
I can actually see that happening because we have doctors that you might not agree with what they're telling you, and you get a second and third opinion, right? And I've played around with that theory just between Claude and Google and ChatGPT. It's hilarious. It's fun. But I think that's one of the interesting things is there are some surprises that I find just leveraging my personal agent, and I wanted to know what you guys are saying.
We have a question from Rush. Earlier, insurance companies were mentioned, and I know providers have a hard time getting payers to pay fully and timely. Do you guys see the payers and providers using AI to try to outsmart each other?
There's a complete arms race. Complete.
Yeah.
There's AI-based denials. Payers, wanted all this open access to electronic records, this thing called Payer Portal, which we complied with. But it's actually led to paradoxically more denials, even though they have more access. So now providers, based on their EMR vendors, now have AI-generated denial appeals letters. So it is really an escalation. Yeah. And then it gets solved by humans who get on a peer-to-peer conversation with the medical director at the payer, and it gets resolved.
Perfect.
Go
ahead.
Which all unfortunately leads to delays and leads to frustration and leads to all the things that you're trying to solve. So
get rid of the insurance companies.
Yeah.
Let's see. Laura is asking, Christopher, before that, Austin, Josh, and Charles, what are the biggest failures that you have been associated with AI? Let's keep it to that. And what are your key learnings?
This actually kind of predates the whole AI thing, but we were building an app for Humana Healthcare, very specific diabetes management for elderly users. And I categorize this as one of my biggest failures because they're still alpha testing the app. We finished it 2 years ago. And Alicia, you joked earlier, like, have you ever worked in big hospitals? And this would be my my closest experience to that. And so the biggest learning is that bureaucracy can really slow things down. If you have multiple boards and committees that all have to approve everything and they all have their own thing that they're looking for, sometimes the best products, the best ideas will never see the light of day.
Yeah, I'll get one through here as well, just to keep the similar theme of supply chain and how we wanted to leverage artificial intelligence robotics. What was a real eye opener, right, is that you have to have the proper infrastructure, even like size of hallways, right? The clutter in the hallways, everything associated with how you manufacture and how you install your shelving, right? All this has to be like super, compliant with the automation. So that was like, okay, let's hit the reset button. Let's not necessarily focus on artificial intelligence, automation, and robotics. Now let's fix these other problems first, right? So that was kind of a reset. Yeah.
I don't think we've done it long enough to have a mega failure yet. I'm worried about our first failure a lot with scheduling, because I really feel like when you really make someone give up control, it's when you're going to hit the resistance. Control is the AI killer. We'll find out.
Let's see. Laura asked, do we worry about compromising the necessary human connection when replacing the human element in healthcare with AI or tech? Are there some physicians or practices where we think that the lack of human connection would be harmful?
I would posit we've had an implementation of an ambient AI, generative AI tool now for about a year, and we have about 85% adoption rate, and we can show the number of hours it's saved for people. They don't have to work on their notes at night. It's been beyond our wildest dreams, well adopted.
Mm-hmm.
But there's 10% of people who won't use it. And there's a lot of different reasons. Some of them come from they feel they don't want everything recorded. They don't feel it's authentically their note. AI never captures the way they want to speak. And a very small subset, increasingly, are concerned about the sort of echo toll of advanced computing. And they say, this is contributing to additional data centers, like it's a sort of a fossil fuel argument, like my one car does contribute to the carbon footprint. My one use of generative AI contributes to the need for mega data centers. We've heard that from a few folks. So I think the resistance is, I don't want to say resistance is futile. That is not fair. Resistance is real, and it should be listened to.
Yeah, and just to add, probably more so on the technical side, if your systems that you're trying to integrate, if that hasn't been done properly, you're just going to perhaps, shoot yourself in the foot. So I would say the bottom line is preparation, and do it in a way where you're not shortchanging the preparations. That would be probably the best approach, even in the smallest AI, whether it be automation or process improvement. Make sure that you're preparing and ensuring that those system integration issues have been resolved, and that will, I think, help you in the long run as well. For other projects.
I have a futuristic question. This is truly futuristic. Do you foresee doctors having an agent or a model that's been trained specifically? We have naturopaths, we have Harvard trained, we have those from Kent State University, right? Do you see being able to leverage AI models to make your practice even better? And Austin, this is like an idea for you to take and run with.
Well, I'm laughing because we're already working on one project like that. So,
well,
one of the concierge health clinics that one of the concierge health clinics that we work with, they have connections with a lot of the like celebrity longevity experts, people with very popular YouTube channels and podcasts and things. And so we're working on a health dashboard with them where you can select your favorite, health expert or longevity expert, and they'll have access to all your blood work, all your, everything from your watch and everything else that you've synced to this health dashboard. And you can get advice from them that's been trained on all of their podcast data. So if you really want to focus on longevity or heart health or this, you pick your expert and they'll analyze your data through that lens and speak to you in their language. But back to my earlier point about the March of Nines, how safe is it to roll these things out? We're very early in the prototype phase of this because giving people free access to talk to these agents and say, no, but don't worry if the research is only experimental. Like, I want to try the latest stuff. If you just keep telling the AI that, it'll start recommending some pretty crazy stuff to you. So
no, I was talking about going to a human. I still want my doctor to
all
be
about
human,
routing it out to a human. Then when
you're right, so with all my credentials, and by the way, I use this particular model that has been trained XYZ and things like that, right?
So
I'm old school. I still want my doctor to cry to say I hurt my toe. That's just me. But I having the agents out there, I think is it's very interesting. But I was just thinking, as we get down further down this road, will doctors actually be having their own AI agents in the background, like a team, telling them,
Oh, I
kind of
see.
like
Yeah,
having them be the guru to say, these are what all of the
exactly.
agents are saying, and this is how you interpret it. And Alicia, it was from your doctor that you had, I forgot his name already, but he was saying that doctors are going to become more like gurus and interpreters of the
Yes.
agents.
Dr. Pitt. Yep.
Yes.
Yeah,
They'll
absolutely. But
take
it
all
was
this
the
advice.
Sherpas is what he said.
The
The
Sherpas,
Sherpas
yes,
is what the
yes,
physicians are going to become. I don't want to miss Thomas. I see your hand raised. Do you want to ask your question and get that in there?
Yeah, Josh, you had mentioned that adoption's hard because some people don't want to, they don't trust that it's getting their tone. They don't understand it. It's not recording them properly. Is that something that you see as a hindrance right now? Is that pretty common?
I think it's actually quite uncommon because it's a very credible note. Let me be clinically, it's fine. But there are some people who it's like authors. Like there are some people who still want to write with their own voice. And I don't know that AI can actually, well, I shouldn't say this. I don't think it can actually become you. Like it can be a credible facsimile of a really good doctor, and it can do all the right steps, but you would still know it wasn't you. And this is very subtle. It's very subtle. Some people are really about knowing it's you who wrote it.
Right.
Um,
Well,
so
I'm
that, yeah.
curious, and maybe Austin can tie this in. So I come from a machine learning background, right? Robotics, automation, autonomous. So we've been dealing with this for quite some time. So think of like your user interface, your touch screen. So we have ML tools that we address how hard they're pressing it. When people are frustrated, they'll go press, 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 and they'll hammer on it. So
Yeah.
we actually encode their frustration level. And when tools are frustrating, we change the way they're working. So I'm curious, those are very much machine learning level things that AI seems to miss. They don't, people don't seem to be addressing that we already know how to do all these things. Are you seeing these things being used?
I don't know that they're that sophisticated. Like if you could take this person who felt it still wanted to be their voice and they read the note and they couldn't really tell if they'd written it or somebody else had, when we get to that level of sophistication, but you'd have to read every one of Josh's notes for 25 years to know he always says things almost exactly in the same way. I've got to believe the technology is there to do it. I just think that wasn't the focus of these generative AI tools. I think their focus was to get a note that hung together and met like the LLM, not the JLM, not the Josh learning module. It's the large learning module.
Yeah.
I'm going to use that. We're not going to use the
The tools are
TLM, not
there.
the Tom learning module.
Yeah. It's just more expensive to do that, right? Because now you have to fine tune a model for every one of your clinicians as opposed to developing just one solution. So it's certainly possible, but it might not just be there cost effective right now.
The challenge back to Austin is as computing becomes cheaper and faster, eventually 20 years from now, it would actually be able to create highly
100%.
individualized models. And then we would actually get replicated by robots.
Actually,
Like
that's what's interesting. When it's applied in autonomy, we actually already do that, and it doesn't use large language models. It uses edge computing. But when you walk into a factory and a lights out facility in modern manufacturing, this goes back 5-6 years. Every user does indeed have a model built around them, and that's because it's all built on machine learning stuff. So I think the AI world is going to explode once they really go decentralized, because again, it's weird because the tools already exist, they're just not being implemented.
Yeah.
Great point.
Well, I think that we could probably take another hour and continue this conversation, and it would be just as engaging. Alicia, I apologize, but I have to take over again.
That's okay. Thank you guys so much.
Thank you
This has
so much,
been
Alicia.
really
And thank
great.
you to all of you, Joshua, Charles, Austin, and Minky, for sharing your expertise and the real world perspective of today. We also want to thank the University of Advancing Technology for serving as the presenting sponsor of our virtual tech speaker series. As usual, your partnership helps make every conversation like this possible. Thank you to all of our attendees and for spending the afternoon with the Arizona Technology Council. I want to make sure that I remind you all that there is some information in the chat for UAT, as well as the events that I mentioned earlier. And the conversation was recorded, and all of our attendees will receive a link to the recording so that they can revisit later, because I'm sure there's a lot of information that you all want to follow up on. Thank you all so much. On behalf of the Arizona Technology Council and our partners, thank you for being here. Have a wonderful rest of your day, and we look forward to seeing you at our future council event.
December 9th, everybody.